The next slide tells you about corneal diseases and corneal abrasions or anything that can affect the cornea in patients following ocular trauma. So corneal abrasion is a simple epithelial defect that you can see if the patient has in the cornea a small area of abrasion. These can be treated, and corneal abrasions have to be stained with fluorescent to confirm your diagnosis. After staining with fluorescent, you have to start the patient on antibiotic drops, and you can patch the eye if required. Usually corneal abrasions will heal within 24 hours provided there is no other associated problem. Corneal edema can also be present and tears in the Descemet's membrane. Another important thing is corneal tear, not only in the Descemet's membrane, corneal tear can involve any layer. It can be full thickness. Again, corneal tear can be full thickness or partial thickness. It can be any of the two here. So here is a picture where you're seeing a patient who has a corneal tear, and the pupil is looking drawn towards the temporal aspect. So what this indicates that the corneal tear has extended into the anterior chamber, and it is causing aqueous humor, probably leakage, and the pupil is showing an abnormal shape. Again, here is a picture again which shows a full thickness corneal tear across the entire extent. Now this is very dangerous because when the corneal tear involves a pupillary axis, the chances that the patient can develop scarring is very high. So when we see a patient with corneal tear, first determine whether it is full or partial thickness. 2, look at the underlying anterior chamber and the pupil and the iris. And 3, we have to embark on treatment of corneal tears with this suturing. Suturing has to be done as soon as possible, and patient has to be given a tetanus injection because of the history of trauma. And usually we use sutures which will align the tear, and the important thing is to tell the patient that there is a chance of development of a corneal opacity, and in the area most of the times the corneal scar will heal completely, but there is a chance that the one area may develop a small opacity, and if that is present at the pupillary axis, there is a chance that vision can decrease. This is another manifestation of ocular trauma. You can have bleeding from the iris or ciliary body, and this is typical of hyphema. Hyphema is the presence of blood in the anterior chamber, and usually it settles in the inferior angle. So you're seeing a typical hyphema, but the hyphema in some patients can bleed after a few days, usually about 3 to 3 days, and that is called a secondary hemorrhage. Now, patients also have to be observed for the presence of 2 complications. One is elevation of intraocular pressure, and that is one complication. The second complication is corneal blood staining. So these are 2 things that we need to watch out for. Who is at risk of elevation of intraocular pressure and corneal blood staining? Those with hyphemas which do not occupy more than 1/3 of the cornea and are present only the inferior 1/3 usually resolve, as long as there is no associated problem. But if the patient has, like you can see in this picture, a total hyphema, the entire anterior chamber is filled with blood, and we are not able to visualize any underlying structure such as the pupil or the iris, this is called a total hyphema. It's a very important entity. Total hyphema is also called 8-ball hyphema, and this can be dangerous because it can lead to elevation of intraocular pressure and corneal blood staining. Elevation of intraocular pressure has to be monitored in the patient, and corneal blood staining is what is seen in this picture. So although it doesn't look like a hemorrhage, it is actually the hemorrhage in the early stages. It will be red, but after some time, as it starts getting resolved, it will take on a different color. It becomes reddish, brownish, and then greenish. So these patients, this is called a corneal blood staining, and here the important point is the differential diagnosis for corneal blood staining is a dislocation of clear lens into the anterior chamber. So it almost looks like as if the normal crystalline lens in the eye is dislocated into the anterior chamber. So that is the differential diagnosis. And for a patient with hyphema, if the hyphema is small, it is less likely to cause a glaucoma, but we should always monitor the IOPs. The treatment for patients with hyphema, again, Before you start treatment, you should get a history, ask for history of trauma, ask for history of bleeding disorders or anticoagulants, and ask the patient. The patient should be instructed to have bed rest and lie down with a head elevated position. And also you have to check for the presence of anterior chamber activity or iridocyclitis and start the patient on steroids. And once the patient is starting to recover, we have to monitor to look for the presence of complications.